Good morning, West Coast. Good evening, Europe. And it's a pleasure to have you all with us. I'm Professor Rafi Beyar. I'm a cardiologist, currently president of the International Friends Associations of Rambam Healthcare Campus, former director of the hospital, former dean of the Bruce and Ruth Rappaport Faculty of Medicine. It is my pleasure to co-moderate this webinar with my colleague, Professor Alon Wolf, Vice President of External Relationship and Resource Development at the Technion-Israel Institute of Technology. Alon.
You remember, it all began just about 2 months ago when you and I had a phone call. A few days after, we both organized a Zoom conference, which we thought, between Rambam and Technion, we thought 2 months ago, which was the latest thing out. And now, you know, everyone is using the Zoom.
Yeah, fascinating. Well, as you may know, Rambam has played a leading role in treating Northern Israel COVID-19 patients. It has also been a leader on the R&D front, where often collaborating with the Technion, whose Bruce and Ruth Rappaport Faculty of Medicine sits next to it. This close proximity has enabled ties between the two institutions to flourish. Many Rambam staff members hold leading roles in the Faculty of Medicine. The COVID-19 pandemic has driven our collaboration efforts to new heights. Researchers and physicians from Technion and Rambam has joined together to develop technological solutions in no time for numerous challenges that have arisen over the past few months. During this webinar, experts from both institutions will present these new technologies. I hope that you will find them as fascinating as I do. Alon, you're muted.
You're all invited to submit questions during the webinar through the Q&A options. Questions will be answered at the end of the webinar by our panelists.
It is my real pleasure to introduce now Professor Uri Sivan, the Technion President, and Dr. Miki Albertal, General Director of Rambam. And I would like to turn the microphone first to President of Technion, Professor Uri Sivan. Uri, please.
Uri, you're on mute. Uri, you're on mute.
All right. Unusual for me. Good evening to our audience, hosts, and participants. It is a great pleasure and honor for me to open this first of its kind joint Technion-Rambam webinar. As many of you may know, Technion, Israel's premier technological university and the oldest university in the country, is located in Haifa, Israel. Besides comprehensive science and engineering departments, it is also blessed with a highly rated medical school located next to the Rambam Healthcare Campus, the largest hospital in northern Israel. Rambam and Technion combined form a formidable alliance covering the full range of expertise from patient bed to medical school, life sciences, exact and data sciences, engineering productization, and even commercialization. The joint response of the two institutions to the COVID-19 pandemic highlighted the tremendous potential embedded in this remarkable alliance. And today, we are proud to give you a glimpse of its fruits. We are living in challenging times. In fact, at least here in Israel, the pre-corona period seems like a different era, when people were still free to roam the planet and life took its peaceful, mundane course. And then Corona kicked in and sent us all to physical lockdown and cyber existence. Specifically, Technion had 1 week to go online, with faculty members demonstrating their ingenious creativity and power of improvisation, which you can judge from the first slide, which is this one. In this slide, you can see our chemistry professor, David Eisenberg, teaching his class online from his refuge from his 5 children that had to stay home since schools were closed as well. I leave it to the audience to identify some of the teaching props in his bathroom. So I'll give you a few seconds to do that. But on a more serious note, on the research front, within 1 month, 50 labs on our campus diverted their research to address COVID-19 challenges. As you can see from this partial list of research projects, topics cover the full gamut of research disciplines, from AI and big data to diagnostics, imaging, search for antigens, robotics, protection gear, and much more. And you can find many more details on these projects in the Technion website. Many of these research projects addressed challenges presented to Technion scientists and engineers by Rambam physicians. Challenges that could have only been raised by doctors working in the front line of the war against Corona. Soon you will hear much more about some of these projects, but there are many more that you can again find in our website. Before handing over to my friend Dr. Halbertal, Rambam's Director General, I would like just to say that the remarkable collaboration that was boosted by this little vicious virus will continue and spread to other aspects of human health. Technion is launching a campus-wide institute for human health, where Rambam will play a significant role. Thank you very much, and I hope that you enjoy the rest of this webinar.
So, hello all. It's a great pleasure to have you with us in this Rambam Technion Alliance. It's really a privilege to be here with all of you. My name is Mickey Halbertal. I am the director of Rambam Healthcare Campus. And I am privileged to be part of the Technion for the last 34 years, or even more, because I was a medical student in the Technion. And since then, all my life, I was working at Rambam, teaching students in the medical faculty. The combination of the Technion engineers and scientists and the Rambam clinician, this is a force, what we call the brain force, that can move ahead and create many opportunities to do what is our mandate as physicians. Our main mandate is to give medical care, but as important is to push the envelope, and this we can do together with the Technion people, and the outcome is unbelievable. The fact of having the Corona or the COVID-19 pandemic created an opportunity. Like every crisis, it creates an opportunity. And the opportunity of collaboration, that the fact that it created gave out amazing outputs, and that you see during this seminar. I would like first to show you some stuff about Rambam, what was happening in the this COVID-19 pandemic and the first wave. I will share with you some of the stuff that we are doing together. Here, 1 minute. And Rambam is the academic medical center affiliated with the Technion. We are serving, we are located in Haifa. You can see by the sea. What you see in front of you is the old campus. And on the left side, the white building is the medical faculty. So the combination and the proximity of the medical faculty to the medical center is extremely important. We are the only tertiary care center of the northern part of the country, 2.3 million people, and with 5,300 employees and 1,100 beds. So it's an active tertiary care center, the biggest level 1 trauma center in Israel. When you look what happened in the COVID, in the pandemic, the COVID-19, Israel had initially in the beginning of March many patients. And fortunately for us, you can see the amount of patients are coming down. And this first wave, we managed to pass quite in a quite good way. At Rambam, we had over 100 patients. 6 of them were ventilated. 2 of them were children, which is another thing that we have to look into. 4 perished, unfortunately, and all the rest recovered. When the Minister of Health came to us, said that we have to get ready for the COVID-19, the first phase, we arranged negative pressure isolation rooms. But this was not enough, so we were asked to build a second phase solution, which was what called the Crown Department of 30 patients and 66 intensive care units. Later on, enlarging the capacity to 66 patients with 32 ICU patients. The phase 4 that fortunately for us that so far we didn't have to use, it's what you see over here down, it's the underground parking lot that we have. This is a circumstance after the 2006 war, that the solution that we had, because none of the hospitals was protected at the time. So Rambam management with Rafi at the head, we built an underground parking lot that transforms to the biggest underground hospital in the world of 2,000 beds. And when we had a request to have a solution for 900 patients, 300 intensive care patients, obviously what we did, we went and we used the underground hospital, we transformed it into a pandemia COVID-19 hospital with all the facility, intensive care and everything. This we are not using currently, but this is a strategic solution that if, and we hope we will not have a second wave, we will have to use this in the winter. But this is only one part of the story. The other part of the story is the, again, what I was talking about, having the brain power. And this was really exciting, having all the industry around us, helping us, creating solution within 3-4 days to all kinds of unmet needs. And obviously, major collaboration with the Technion. So in this webinar, you'll hear some of the collaboration. One of the things that you will not hear is a collaboration with personal protective gear equipment that was made by Professor Ezri and the staff of the Hospital of Rambam, Oren Kaspi, and Nati Horowitz. And in order to get our staff protected while treating in really difficult circumstances, heat and everything. And this is one of the solutions that this collaboration built. So I hope you'll have a great evening. This is in the Independence Day, the Israeli aerobatic team, Israeli Air Force aerobatic team, gave tribute to the medical staff of the hospital. And what you see down there below the airplane is our Rambam Healthcare Campus, and this is the medical faculty. So Uri and all the rest of the staff, thank you for joining us and helping us, and have a great evening. Thank you.
Okay, well, thank you, Uri. Thank you, Miki, for the presenting the Technion and Rambam. And it's really amazing how this collaboration brings together the academia, the hospital, the industry together. We'll hear just the tip of the iceberg of what has been done and what is currently continuing to be done here. I would like to first introduce the first couple of researchers that work together. Professor Naama Geva-Zatorsky is an assistant professor at the Rappaport Faculty of Medicine. She joined the Technion faculty in 2017. Naama did her postdoc research at Harvard Medical School, and she worked together with Professor Michal Paul from Rambam, that is Director of Infectious Diseases Institute and a member of the Clinical Research Institute of the hospital. So please, we're excited to hear your project.
I would like to, okay. So this was truly an amazing collaboration between the Technion and Rambam. I have to say that the project that we will present here is off the route of the normal studies that we do in my lab. We usually study the gut microbes. However, a couple friends of mine called me from Boston and triggered this idea of this very rapid test for corona. It took me a couple minutes to think about it, and then the whole lab actually came together. I called Michal Powell, and very quickly Michal also agreed to be part of it and did everything she could to make this happen. Moran Schwartzworth-Cohen, the head of the virology lab at the Rambam, was also all into it. Yuda Chovers, Marini Talmong, and Shimon Pollack all enabled us to work very fast, and it was a major part to work on these human samples and to work with Rambam. It actually made me feel now really at home in Rambam across the street here. Also the lab, all the lab personnel that are here in the picture, actually in one of these days, came as soon as we talked about this, and we actually didn't leave since. So it was about 10 days in lab, sleeping on the couch, and this is why we look tired here, but we were very satisfied by the outcome. So the idea was to develop a protocol to analyze, to detect the coronavirus from samples directly from patients. And it's a very simple protocol. So it can work on saliva samples. It can be self-tested. So the person can spit into a tube, incubate this tube in room temperature, no change of temperature for a while, and then adding just a little bit of hot water, a little bit of cold water, and you can see the results. It was really like that. We even made this reaction in a thermal cup. So a negative result is pink, a positive result is yellow, and these are actually the tubes. So here are negative results, which were pink, positive results, yellow, very simple. One temperature for the reaction, and the results can be seen with the naked eye. So we tested over 200 samples from Rambam. This graph is a little complicated, so I'll explain. The x-axis here are the actual results, the numbers that we get at the hospital that Moran receives when she tests the patients. And our test is positive or negative. So we see that from the swabs of patients, most of the patients up to this number, 28 is actually a number that can tell us how many viruses are there. So up to a number of 28, our results are positive. When the number is higher, meaning a very low viral load, we still cannot detect it, but we have several ideas to increase the sensitivity to see even viral loads that are low. So if the patient has medium to high viral load, we can easily detect it. If the patient is negative, we rarely get a positive result on a negative patient, only 1 out of 200, or in this exact protocol, it was 1 out of 30, and even that is because we were very cautious. So after 40 minutes, we can see the results, and in a viral load of medium to high viruses, it's over 96% accurate. And what I've showed you in the previous slide was on swabs, and we also tested it on actual saliva, like the original idea. So these tubes are from patients that were confirmed by the regular standard method to be positive. We see, let's start at the bottom, these patients at the beginning of the reaction are pink. After 35 minutes, they become yellow. The negative control here remains pink. We also tested it in Moran's machine, and these are the numbers that we get there. We have a positive control, which is a human gene, just to show that the reaction worked. And when we don't add the primers, which is part of the reagents, these are pink. So the idea here is to reduce the complexity of the tests. As Michal Powell was there with us brainstorming all the time, and she will elaborate in a moment. The idea here is to add a test as a surveillance that is simple, can be performed at home even, or at the entrance of the hospital, or in clinics, cheap, simple, and relatively fast and easy to interpret. So this can be applied at homes, at workplaces, and complement the actual standard technique, and actually reach out to the whole population in rural places and in the industrial world, so that we will have a better knowledge about the spread of the virus. I will turn the baton to Michal Powell, but just say that I apologize, but I won't be here for the question and answers, but I have a very good colleague from my lab, Tal, that will answer all your questions if needed. So Michal, I'm passing this to you.
So thank you very much, Naama. It was wonderful to get to know you through this pandemic. Thank you, Corona.
Likewise.
So I think that the need for rapid and very simple diagnosis is quite clear. My slides are pretty trivial. Managing the suspected patients was a major challenge for the hospitals, and the stress here are on the suspected, because a lot of patients came into the ER with influenza-like symptoms, a very common complaint, or just other non-specific complaints, and they were suspected of COVID, and the hospitals had to deal with them. The very large majority of the tested patients were negative, but these negative patients had to wait in quarantine until we proved them to be negative. And if it takes 6 or 8 or half a day to get the negative result, all this time they have to be quarantined with a staff required to keep the respiratory isolation precautions. This results in exhaustion of the isolation rooms in the hospital, waste of equipment, the staff is tired, delays in diagnostics or interventions for all those patients that do not have COVID. They have something else that has to be investigated, and during this intervening period until the result, there was some delays and delays in admission to high-risk non-COVID wards, like our bone marrow transplantation ward did not want to admit patients with COVID, obviously, and these patients were delayed from receiving the care they should receive in their departments. All this attests to the importance of rapidly diagnosing these patients in the hospital. You can pass the slide, Naama. And obviously a rapid and convenient diagnostic like Naama was proposing to me at the beginning of their challenge and amazing trip through this pandemic. This rapid diagnostic could shorten the time to patient triage. It would free the wing in the ER that was reserved in Rambam for the respiratory or suspected patients. It moves forward the whole management, the whole care of the patients. We put to better use the isolation rooms in the hospital, and obviously it can reduce the lab workload. And we can move on. And if we move out of the hospital to the community and to the broader national level, of course, the testing at home has its advantages. It will reduce the pressure on the hospital's emergency rooms. People can test themselves at home. For this purpose, the test doesn't have to be 100% sensitive and specific. It doesn't have to be 100% precise. It can be 80, 90% precise, and the patients can then be tested with a more precise test later on if needed. For the epidemiology of the pandemic, for the contagiousness of the pandemic, this is extremely important because positive patients can be quarantined or transferred safely to patient care settings after they have tested themselves at home and found positive. Of course, those that are negative can be can see their family and can meet friends and feel safe. So the need is clear, and I hope very, very much that Naama will and her team will get there, and we'll see a real revolution in the management of COVID-19.
Thank you very much. Thanks also actually to the Technion that enabled us to do this as it is off route. Thank you, Michal. Thank you, everyone.
Hi again, really fascinating. Thank you, Naama and Michal. I'm sure there will be questions, and we'll keep the questions to the end. I would like to shift to another topic, again with diagnostics of pooling for mass detection of COVID-19. And I would like to introduce Professor Roy Kishoni, Dr. Moran Schwarzkopf, who work together. Roy is the Marilyn and Henry Taub Professor of Life Science in the Faculty of Biology at the Technion. Dr. Moran Schwarzkopf-Cohen is the Director of Virology Laboratory at Rambam. She's a Technion graduate with a PhD in genetics and molecular biology. Roy and Moran, go ahead.
Hello, hi everyone. So my name is Roy Kishoni. I'd like to present a pooling method that we developed to really much accelerate and increase the capacity of the PCR-based COVID-19 tests. The work was done in a collaboration, very tight, very productive and powerful collaboration between the Technion and Rambam. I want to say personally also very enjoyable and even inspiring to see how so many people came together in both institutions, really breaking walls between disciplines and making it all happen very, very fast between the academic lab and all the way to the clinic. In my lab at the Technion, the work was led by Dr. Idan Yelin, Noga Aroni, and Nat Tamar, and we also joined forces with the lab of Yael Mandel Gutfreund, with Amir Argoti, and at Rambam Medical Center, the work was led by the heads of the clinical laboratory, Dr. Yuval Geffen, Dr. Moran Schwarzkopf-Cohen, and really with much help, facilitation, and inspiration from the director of Rambam, Dr. Miki Albertal. So with that, let me explain what is pooling. Pooling basically is a very well-known classic old approach where instead of testing each sample individually, we're going to pool many samples together. How does that look? Okay? So imagine a population like we have now, where most of the individuals are actually negative, and only a few, one shown here, is a carrier of the disease, maybe symptomatically or asymptomatically. And what we want to do is actually two things. We want to first estimate the total number of carriers or the fraction of carriers in the population, maybe on a whole country level, maybe on a city or town level, down to a neighborhood, maybe in individual buildings and so on. And we also want to identify these individuals to limit social contacts and limit further epidemiological links. So we're going to start by collecting many samples, and then normally, classically, we're going to measure each of those samples. Again, it's very, very tedious, and ultimately, all of them, most of them are going to be negative, one is going to be positive. We're going to identify the person who carries the disease. But to do that, at scale, imagine tens of thousands, hundreds of thousands such tubes, it's challenging to almost prohibited and impossible. So what we can do instead, and that's the pooling idea, is to first pool the samples into bigger mixes, what we call them the pools, where many samples are collected together into one tube, and then we can just measure those tubes individually. If all the samples that went into a pool were negative, the pool would be negative, and if even one positive sample that went to a pool is positive, then presumably or hopefully, and that's a big question I'm going to answer in a second, but presumably we might be able to identify that pool as positive. So from this data alone, the negative and positive pools, we can already pretty well estimate the total fraction of carriers in the population. And also, if we wish, we can go backwards to the individual sample that made the positive pool. But importantly, we don't need to remeasure the one that made the negative pool, only those that made the positive pool and identify the positive individuals. There are also some combinatorial methods to do that more with kind of more efficiently, but I won't get into that. But the basis for all of this pooling idea is the ability to detect a single positive sample when mixed together with many negative samples. And the question was, can we do that? And how many samples can we even mix together without losing sensitivity? So to do that, we took a series of positive samples, real samples from patients, some with strong signal, some with weak signal, and also took a whole cohort, big cohort of samples that were negative, also real from patients, and start to measure a sample alone. And when we mix them in pools with negative sample, a pool of 2, a pool of 4, and if it crosses that threshold here, that means we've detected it. Okay, a pool of 8, a pool of 16, a pool of 32. And here, even a pool of 64, so a single positive sample mixed in a pool of 64 can still be reliably detected. Overall, in this particular example, overall, across all samples, we've established a limit of up to 32 samples mixed together can be reliably detected. So you can imagine that can really save a lot of resources. How much? How much will depend on how many we put together, which really, and on fraction of positives in the population. Here are two examples to get some numbers. If the fraction of positives in the population is 1%, then optimally we would want to mix about 10 samples per pool, and that would amount to saving of about 80% in resources in total number of reactions we need to run. And if the fraction of positive in the population is even smaller, say 1 in 1,000, then a pool of 30 would be optimal, which again, that's exactly what we've shown we can do reliably. And that would amount to saving of 90 or even close to 95, but truly over one order of magnitude saving in the number of reactions, number of resources, the number of PCR machines, and so on. So with that, let me conclude. I've shown you that we can reliably detect a single positive sample even when mixed in large pools up to 30. That really established the foundation for this classical idea of pool testing, the foundation to implement that idea for COVID-19 to much increase the capacity and throughput of the approach. The method is based on standard equipment, standard reagent, and can therefore be applied immediately. In terms of applications, I've mentioned a bit the idea of population surveys, which could be very important. Another application I will mention is the screening of what I like to call organic or cohesive groups, like army units, factory shifts, hospital staff, where really the functioning of the group itself as an entity depends on neither of its members being a carrier of the disease. So thank you, and with that, I'll transfer the microphone to my colleague and teammate, Dr. Moran Schwartz-Cohen, from the head of the virology lab at Rambam Medical Center. Thank you.
Thank you, Roy. It was a pleasure working together. The last 3 months have been very challenging for me and my team in the virology laboratory at Rambam, and the same thing can be said for all corona labs all over Israel. In the beginning of March, when SARS-CoV-2 started spreading in Israel, the virology lab at Rambam was one of only 4 laboratories in Israel that quickly developed and adapted molecular tools for the positive diagnosis of COVID-19 patients. Several weeks later, when there were more than 30 corona labs in Israel, all licensed clinical labs. Naturally, there was a national pressure to immediately start the process and diagnose hundreds of samples every day. But challenges were many, including lack of reagents and essential equipment such as real-time PCRs and nucleic acid extraction robots. One of the main challenges we faced and needed to solve in this stressful situation was our ability to increase the efficiency of the diagnostic process. We were required to quickly process and analyze a large number of samples each day without having the proper patient history and background information that it is usually available to us under regular circumstances. The pooling methods allows us to achieve this goal and to expand our screening capacity, thereby enabling greater detection during routine monitoring in a community. This method is well known, and in this situation, it was a very good, efficient tool to apply, but it required first a systematic validation of this specific virus and the mind switch between the daily ongoing large demand for tests and the development and testing for this future strategy. Working together with the Technion was inspiring in these stressful moments. Indeed, in times like this, when we face emerging threats and challenges, that it has become even more important to be able to take theoretical ideas from the research laboratory and apply them in a clinical laboratory. The transfer of knowledge from the research lab to the clinical lab could be the difference between the control of the epidemic versus expansion of the virus. Although there are inherent gaps between these two worlds, such collaboration can produce highly useful and out-of-the-box solutions and bring tools to improve overall health services. Although most of the problems were solved in the present wave and the testing capacity was successfully improved, we will continue to prepare our labs in order to be ready and much more experienced in the future. Thank you.
Thank you.
Well, thank you. Thank you for the wonderful presentation and the wonderful research and innovation. And now we'll shift, and remember, you can type in your questions. This will be handled at the end of after the next couple. The next couple, actually, we're moving to robotics, and I would like to announce the co-robot care for hospitals, and this will be done by Dr. Nati Horowitz and Professor Gil Yudilovich from Technion. And Dr. Nati Horowitz is director of the ambulatory care unit at the hematology division at Rambam. And Gil Yudilovich is a professor in the Faculty of Aerospace Engineering since 2015. He joined the Technion after a brilliant career in Rafael. Gil received the Israel Defense Prize in 2014. So Nati and Gil, your stage.
Good evening, everybody. It's a pleasure to be here. So let me start with a picture to define the need. You can see here a team of physicians and nurses. They are wearing special protective gear. We call it protective personal equipment. Well, this equipment, it's hot, it's sweaty, and it is not comfortable. It's not 100% safe. You can wear this equipment for 2 to 3 hours before you must undress and get some rest. Now let us talk about the environment. It is probably contaminated with COVID-19 aerosols, and it's crowded with patients and medical equipment. So what is our mission? As Dr. Halbertal said in the beginning, we want to give the best medical treatment to our patient, while in the same time protecting our staff, physicians, nurses, and logistic personnel. We want to cut to the minimum, if we can, the time spent inside the COVID-19 ward unnecessarily. And by doing so, we can also save time and cost of medical personnel. So we collaborate with Gil's team to develop a robot which is remote controlled, it's reliable, safe, and easy to use. We want it to be able to communicate with the patient and to carry medical and other equipment. By saying we, I mean a team of nurses, physicians, and logistic crew who define the desired characteristics of the robot. While in the process, we thought not only on the COVID-19 scenario, but on other challenges we could face in the future, and in particular, using the Rambam underground fortified hospital at the time like war. So working with Gil's team was challenging, instructive, beneficial, and surprising. Why surprising? Because it wasn't an ordinary team of scientists. And to learn more about the team and the results, I will turn over to Gil, and we will hear from you, Gil, the rest of the story.
Thank you, Nati. Thank you very much, and shalom all. Based on those needs, we prepared a 4-step plan. The first step was to rapidly develop 2 prototypes of the robot. Check, done. And then we performed 2 demonstrations in 2 different Crown departments, one overground and the other one underground, was mentioned. And the first demonstration, by the way, was done about a week after kickoff, and the second one about 5 weeks later. Currently, we are in the 3rd phase, 3rd step. We're focusing on the upgrading of the 2nd prototype in order to deliver it to the hospital as soon as possible for training and testing. And the next step will be to prepare to provide more robots if needed for future potential coronavirus outbreaks. This step will end with a full production file, including operational and maintenance manuals. So as Nati already said, the team is a kind of a different team. Because of the short time, we look for someone who can build a robot very fast, and we recruit the first robot. First is an organization for robotics, the first robot competition group called Galaxia of the Hebrew Reali High School in Haifa. These guys are specializing in building and operating robots for competition. However, because this robot, the required robot, is not a competitive robot, we have to work in a collaboration with some other students from the Technion and also students from the University of Haifa and some professional volunteers as well. What is the products that we have developed? First of all, the robot can deliver food and medical cargo up to 30 kilograms. It has a rechargeable battery up to 10 operational hours, which is a lot, between charges. And easy operation via an application on the user smartphone, tablet, computer with optional and recommended joystick. Since we cannot use radio communication inside the hospital, we built a communication based on the hospital's secure Wi-Fi network. This allows us to operate the robots that can be in any Crown department from any location in the hospital. Another thing that the robot does is the communication, peer-to-peer or person-to-person communication, which is very similar to the internet video chat that we all know. For safety, we have a warning light and a buzzer to alert people while the robot is moving. And the robot has also two wide-angle video cameras, front and rear, for safe driving and orientation. And the robot has easy maintenance capabilities and procedure, and mostly important, easy disinfection process as well. More about the robot in the following short video clip.
הרובוט הזה בעצם נוסע על 4 גלגלים, מה שאומר שיכול להסתובב בעצם על ציר סיבוב שעובר במרכז הרובוט, וזה באמת מיועד כדי לאפשר כמה שיותר תנועתיות במרווח הצפוף של בתי החולים. יש לו פה מצלמה, שבעצם מאפשרת למי שנוהג בו 170 מעלות של ראייה מסביב. על הרובוט בעצם יש שני מגשים, יש לו פה מגש עליון ופה עוד מגש תחתון, שעל המגשים האלה בעצם אפשר לשים כל מיני דברים, ועל המגש העליון פה איזשהו מתקן שהוא גם אבטיפוס שיחזיק טאבלט, שיאפשר לתקשר עם חולים או עם צוות רפואי שנמצא בעצמו בתוך האזור המזוהה.
אנחנו ניסינו לתת לממשק משתמש כמה שיותר קל ונוח לשימוש, שיכול לעבוד על כל פלטפורמה, אם זה טלפון, טאבלט או מחשב.
Okay, two things about two different scenarios that the robot is working. The delivery and driving scenario. In this scenario, the user, the operator, uses user interface, which is the commercial joystick and smartphone, tablet, and he can stay in any place in the open spaces of the hospital. And in driving the robot inside the Crown closed department via the Wi-Fi of the hospital to any recipient in the department, either a patient or a staff member. When you're doing it, he has a screen. On the screen, he has a few touch screen control buttons and two views. The big view is for the driving, the video view for the driving direction, and the small one is for the opposite direction. And also he has a graphical indication of the location of the robot inside the hospital. The second mission is much simpler. It's only to create a person-to-person communication channel. This is also done only using the Wi-Fi hospital with no cellular communication, of course. The robot is standing in this position, and the operator and the recipient in the isolated department can do a video chat to instruct the patient to take the drugs, etc. I like to end with some thanks. First of all, I'd like to thank the Technion and especially Professor Alon Wolf for their support and for allowing me to give me the opportunity to lead this project. Of course, the Rambam team and especially Dr. Nati Horvitz. I think it was a very useful cooperation between us. Many thanks to the Galaxia team, which include students, very young students, graduates, teachers, mentors, parents, and volunteers, especially for their determined teacher, Tirza Orberg, and their supportive principal, Dr. Yossi Bendorf, and also many thanks to our volunteers, and thank you.
Thank you, everyone. And we got some interesting questions about in this stage. I'd like to ask, the first question came from Andre. It's for the pooling method. What if in the pooling test, you identify positive results? You know, what do you do with all the tests that you have in this batch? I guess, Roy, this is a question for you.
Okay. So the question was, what happened if in the pooling test we identify a positive result in the pool? And the answer is the data actually depend on the application. If the application is simply to survey the number of positive carriers, the fraction of positive carriers in a group, in a population, in a town, in a city, then we actually don't need to do anything. We just need to count how many of the pools are positive and how many are negative, and just the ratio between these pools can give us an estimate, a fairly good estimate of the ratio of positive to negative in the population. If what we want is actually to identify the specific individual, then we would need to go back to the individual sample, but not to the patient. But individual samples are saved in the backlog of the lab. We go back to the samples and either measure them individually. There are other more kind of efficient technique, like to do binary, to do them to divide them again into subgroups and other techniques. I would also mention that there is an application I mentioned at the end of monitoring cohesive groups, organic groups, like I mentioned, the ARM units. In that case, if you really take the samples that you mix in a pool are related in the sense that all of them come from people that are part of, that are members of the same team, then the pool being positive or negative without knowing who is a positive person is an operational information by itself, because normally if the group can keep functioning if all of the members are negative, and if even one is positive, we would typically send people back home even before we know, and sometimes even it doesn't matter who is a positive individual. So I think I've covered several options, and thank you for this good question. Thank you.
Thank you, Roy. Thank you. The next question came from Samuel Alevi, I guess from the USA. Who or what gets the credit for the extremely low mobility in Israel? And he gives the example of what is unfortunate events now in the United States and the horrible numbers that we all read in the newspapers. So Mickey, maybe you can give your view of that.
Yes, I think that this is a combination of few things. No doubt, the first thing is the brave decision that was decided by the Ministry of Health. The fact that from the beginning, they looked at it as a big threat and basically made good decision of isolation and closing the country. So the initial decision of the Ministry of Health was extremely vivid and it had lots of impact. And I think that there are other factors that are involved. Is first, we're a small country, as you know, and the fact that there is only one entrance, one big entrance, which is Ben Gurion, so is, though the isolation through there and was not the best, but still it was much more simple than to have a few accesses into the country. And again, and another one is the fact that we are a young population. Israel is considered to be still young, though aging really quickly. And I think if you look at all the factors, I think that this is what made the difference. I think that what's happening now is that though the response of the Israelis, they are not really abiding all the rules, but I think that what's helping us now is a little bit the weather. We had one of the worst weather, a week of really high temperatures, and I think that this is also another impact. So I think all those combination is what brought the amount of patients down so quickly. Thank you.
Thank you, Miki. Next question goes to Gil and Netanel again. And Gil, there's a question if you can elaborate a little bit more about your experience working with the school students, because as mentioned briefly before, you come from a very prestigious, I would say, research institute, industrial institute, where you work with elite engineers, and here you have to work with school students. If you can talk a little bit about this, and to what extent the robot is ready for use in, for COVID-19, and maybe even in a regular base in the hospital. This is maybe a question for Netanel.
Okay, as you said, I used to work with in engineer for about 35 years, and then I have to get used to work with academia for almost 5 years. And now I found myself working with young kids, very talented kids, by the way, brilliant kids, but no discipline, no, you cannot force them to do anything because they want to do what they think is right. But somehow we manage to work together. Especially, I think I have to give up on my regular ways to run such a project. And eventually we succeed, we learn to each other and found a way to work together. And I think for me, it was a very nice experience.
So for Rambam, it was also a unique experience. We are a hospital that serves the community and for the community, and it was like that the community is helping us to cope with the COVID-19 situation. So we liked it very much. And I think that this robot is unique because it was and it's still developed for Rambam requirements. We have an experience with other robot developers, and I must say that this robot have abilities that others do not, like the ability to carry equipment, different kind of medical and other equipment. And we saw during the demonstration that you have to adopt the robot for every ward that you want to use it in, but it's doable and it's not hard. And I think that in the future, even as I say in my presentation, this robot can be used in other scenarios other than infectious diseases. And we would like to see it happen. So I want to thank Gil again for his team and all the help they gave us.
Cooperation.
Gil, another question here for you is how secure is the communication channel for the robot? Can someone hack into the system?
Well, I think that this question is also, you have to ask the hospital, because we are using the secured. In the hospital, there are two Wi-Fi communication channels. One of them is public. You know that when you come to the hospital, you can connect to the Wi-Fi. This is a public, this is unsecured net, and of course we are not using this net. We are using the secure net, and you know that in this net control many other information and machine and infrastructure that it's very important to keep it secured. And maybe the people from the hospital can elaborate more about this, the security of the network.
Yes, so the network is really secured. As Gil mentioned, we use it for other stuff, even for delivering patients' data, and Dr. Halbertal mentioned before that we developed together with the industry, especially Elbit company, a special control and monitoring system that can aid us to control the staff, the undergrad hospital. So we made sure, together with the authorities, that it is secure and we can use it.
Thank you. The next question goes to Naama and Michal. How reliable are the tests now, and how many can be distributed?
Sorry, how reliable and how what?
How reliable and how many can be distributed? Please unmute yourself before you answer.
Naama unfortunately had to leave for another meeting. I hope I can answer. I think, as I mentioned, this is a good screening test. It's a good test to triage populations, large populations. And then the borderline cases can be tested with a more reliable test. So it's not 100% reliable, but it's a very, very good and efficient screening test. I don't think it's ready for commercial use as of now. I think, but Naama is striving very, very efficiently towards having a commercial test as soon as possible.
Well, hi, my name is Tal, and I will try maybe to elaborate a little bit on this answer on behalf of Naama. So for now, the Technion and the Rambam Institute are in contact with few commercial companies that are very interested in this concept. And we know that as far as last week, the FDA approved the concept of this method as a method that is approved to test and screen for the COVID-19. And regarding the availability of the kit itself, so it's not a complete kit because we use it as a laboratory setting, and it's not a whole kit that you can now buy in a closed box and use it. But if a company will close a deal with a commercial company, obviously, will close the right deal with the Technion and the Rambam Institute, I guess that it will be closed in a kit that will be available for the hospitals and the various institutes. So for now, it's only on the setting of a laboratory.
Michal and Tal, there is another question from Paolo Barbanetti Bonacera. May I have more information from Italy, of course. May I have more information about IP positive of diagnostic kits and if they are available for licensing out? And I think part of was given the answer. Can you?
Yeah, so as I mentioned, it's in the process now. For now, again, it's in the setting of a lab usage. We haven't enclosed it into a closed box, and it's not available for commercialization yet. It's need to go through a process, but it's there. It works. It works in the setting of using equipment from the lab, but obviously with the right methods and the right company that will push it ahead, it will be available as a kit. Yes, definitely.
Another question to the pooling method. Can the pooling method be adapted for testing for other viruses or illnesses?
I can answer it. Of course, pooling method is a well-known method for screening in the population. Can use for other viruses, but it all need to be validated in the laboratory.
Attitude towards.
Can you say a little bit more about the health attitude for the pooling method? What is the general attitude about this? How useful is it? You know, how many people use it?
There are some laboratories in Israel that already use it. It needs equipment, robot equipment in order to avoid mistakes and be able to return to the first samples, to the original samples. As Roy said, you need to, in some cases, you need to be able to go to the first samples and be able to diagnose the specific sample that was positive. So,
yes, sorry?
It's already not in use at Rambam, but it's already used in other laboratories in Israel.
Thank you. I guess the last question is, what is the, this is for the doctors here and the MDs, what is the probability of a second wave similar to the Spanish flu? This is a question by David Pertia. Maybe Miki or...
Cannot switch on, okay. Well, your guess is good as mine. We have to understand that prophecy is for the fool, but I think that there is a good possibility, and if you look at the algorithms and we see what's again happening around the world, that first we know that we'll have to live with the corona COVID-19 patients until we'll have a vaccination, active vaccination work. And I think that coming into the winter with the current flu and corona, I think that we have to be in a set of mind that we will have to have a solution for another wave. Will it be a big wave? How we will be able to control it? It really depends on the how will the Israelis, like all over the world, will respond to the rules of isolation and hygiene, wearing a mask. And us as Israelis, we are not very good in following orders. So this is a big question, and this is why we all have to use this precious time before the winter to be ready and to have the best solution that we can for a wave like this.
Miki, thank you. I want to thank you, the audience, for sending all those interesting questions. We had many, many more questions. Because of lack of time, we cannot answer all of them. We will make all the efforts to respond by email to those of you who shared the email or the names with us. We will answer them personally. Rafi, maybe a few words from you.
Yeah, well, really, I would like to thank you all for joining us at this exciting webinar today. I think it was exciting. The last few months have been challenging and uncertain for all of us. And while no one can predict what the next few months will bring, as we mentioned, a second wave or not second wave, you can be sure that researchers and physicians from the Technion and Rambam will continue to work together for the benefit of all and for all kinds of diseases and challenges that medicine and life science bring to us. So really fascinating. Thank you all.
Rafi, thank you. I don't know if you could even imagine what would be the results from this phone call we had a couple of months ago.
True, that's true, yeah.
I want to thank all of you for taking the time to be with us this evening and wish you good night and good luck. Good night.
Thank you. Good night to all.